As a student, if you walk into clinical next week, what is your role, or what are the limitations as far as your role? What do you think, your scope of practice? What can you do, not do, what can you expect to do? If you walk in as a student.
Compression.
You can or can't do compressions?
We can.
Absolutely. Everybody's got your BLS updated, right? Because like tonight, I gotta start going through all that, make sure you don't go to clinical. You got your BLS updated. Yes, it is within your scope of practice to do compressions. It is not at all uncommon for students, like their first day, this seems to happen the first day, it's always the first day of clinical. Their first day in the ER, like it's literally walking in, actually, ask Ms. Griner how many times this has happened. You walk in, everybody's just like putting their stuff down, and there's an arrest coming in off the ambulance that they've been working for a certain amount, for however long, but they're not gonna call that in the field, they're gonna get them to the ER, let the ER doctor evaluate, see if there's anything else we can try or do. And they say, hey, you're a nursing student, you ever done compressions? Here, now's your turn, okay? It may happen, it does happen sometimes. You are prepared to do compressions. You learned, you have updated, you know how to do CPR. Okay? So don't panic, don't think about all the things that you don't understand going on around you. If you're asked to do compressions, you do compressions. It is within your scope of practice. It is not cheating the patient. It is not, giving up on them, although you may be in situations where everyone feels it's futile at this point and they're just checking some last things off before they make that final determination, as hard as that is. But that doesn't mean you're not giving them good care. You are qualified to do CPR, period, okay? So, I want you to feel empowered to do so, if you're asked. You don't run, you don't hide. If they say, have you ever done compressions, or do you want to do compressions? The first answer may be no, but the second answer is yes. I would like to. I want to have a chance to do that. And what better time to do it for the first time than when you're a student and everybody around expects you to not do it right, so that they're watching more carefully to say, you need to go harder, you're not going hard enough. Actually, one student go way too hard, I don't know. So remember that, that's the craziest thing, like, you know how you usually have to tell new people, like, harder, 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 I had to tell her back off, like, anyway. Like, logic but what better time to do it for the first time than when you're surrounded by people wanting to help you? Right? Okay. What about, let's talk about roles in the code. And so some of you have seen some of this where you've worked over the summer. Every hospital is gonna have a little bit different situation as far as the code team. But I feel pretty safe in saying, even though I haven't worked at all of them, that all of them have a code team, okay? You call a code, some people are gonna show up. Who's gonna show up?
Respiratory.
Respiratory therapy. What's respiratory therapy's role? Intubate. Some hospitals that offers always intubate. Where I worked in Michigan, I never saw an RT intubate. At Piedmont Mountainside, the oftentimes RT intubates. And it's not just tiny hospitals, some bigger ones do too, I mean, it's just different. But respiratory therapy, they may intubate, even if they don't intubate, they're gonna usually take over bagging, or at least take turns with that, handle the ventilations. By bagging, does everybody know what I mean by bagging? We're talking about the bag valve mask to provide breaths, right? They may insert an oral pharyngeal airway or a nasal pharyngeal airway. Got some examples of those, I think, we'll look at. But they're gonna handle all things breathing and oxygen, right? They may delegate, they need some help. I mean, a nurse may need to help them, but that's gonna be kind of their thing. Who else is gonna show up?
House coordinator.
The house coordinator, or house supervisor in some places they're called. Housewide supervisor is another name for it. What do you think their role is gonna be?
Moral support.
For everybody, yeah. They do a whole lot of whatever the heck is needed in the moment, right? So they may be on the phone calling families, they may be able to delegate that to a unit secretary. There's a lot of different roles that you might see that housewide coordinator doing. But overall, they're watching for what needs to be done and making sure it's getting done. Would you have any, what about your house supervisors or house coordinators?
We don't have one.
Okay. I would think you would have like 3.
We only have them on nights or
Okay.
weekends.
Okay. So, but this is exactly what I'm talking about, that every place is gonna be a little bit different. Who else? You said something, Erin. Who else?
The charge nurse, or the nurse that has that patient.
Charge nurse and the nurse that has that patient, right?
COVID attack.
Yeah.
The tech, now, it's interestingly, some places do this and others don't. The first, where I had worked before I moved to Michigan, I really had a lousy understanding of what I should and shouldn't be doing in a code, I think, when it was my own patient, because the first time an ER tech showed up and was like, I got compressions, I got this, and goes in and started doing it, I was kinda like,
Those are my compressions.
ER tech to do my compressions for me? Because you're a boy? Stupid, y'all. That was dumb, that was really dumb. Why was it dumb? Why was that a terrible attitude for me to have? What was I missing?
Because anybody can do the compression.
Right.
The tech's
Say
not.
that last part again, nice and loud.
You could be doing other things that only you could be doing and not a tech. It's all
Yeah,
about
techs can't give
delegation and
medication.
what can be delegated.
Who knows the most about that patient?
The nurse.
So their nurse. Who knows the most about what medicines that patient's had that day? Who is gonna be one of the most important people for helping determine what led to the cardiac arrest in the first place?
Yeah.
That nurse. How effective is your brain 10 minutes into staying alive, right? How effective is your brain 10 minutes into that?
Not. You're too busy singing.
Right, too busy saying you can't do it, no? So, when you're, those first few compressions and all that adrenaline, man, you're on it. But your focus, the person doing compressions needs to be focused on how fast and how deep, and on switching off, and on high quality compressions. They are not gonna be at their best to engage in the conversation about what caused this and how can we stop it, right? So, if it's your patient and you find them, please don't stand back and wait for somebody else to do compressions, obviously, right? You're gonna start it, but as soon as your team is there, somebody else should be stepping into that role for compressions, you know, as soon as you have enough people there. Who else is gonna show up on a code team?
The doctor or physician.
What's that?
The doctor or like the physician is on call.
Physician, PA, nurse practitioner. Now, what time of day, what hospital you're in, and what the patient is in the hospital for are all gonna impact which doctor or doctors show up. But there needs to be, at least one physician is gonna be part of that code response, okay? If the patient has had surgery, that surgeon's gonna, unless they're in surgery, they're gonna be showing up, okay? So you're gonna have a physician coming in. What's the physician's role? Run the code. So the physician will give orders. What's the difference between BLS and ACLS?
ACLS, you can push the drugs.
Yeah. ACLS stands for advanced, the A in ACLS stands for advanced, okay, advanced cardiac life support. So, if there's a nurse there, and there will be as part of the code team, if they're, even if you're on a med-surg floor and those nurses are not ACLS trained, somebody on the code team will be. As long as there is somebody with ACLS there, you do not wait for the physician to give drugs, because it is within your scope to follow the protocol. There are very specific protocols, you give certain drugs for certain things, and you can give them as an ACLS nurse. Okay. Who else might show up? Chaplain. If your facility has a chaplaincy service, absolutely a chaplain will likely show up. Huge in terms of helping the families, huge in terms of helping the staff to deal with what's happened. I didn't even realize I remember one time after a particularly ugly code situation and a really sad situation, somebody we lost, we had to take care of a good while, and the chaplain was there, and they'd already walked the family out, and I noticed it was like both of them there, Ron and Jim were both there, both chaplains we had a strong chaplaincy service there. And they're kind of standing there hanging with me, and they're chatting with me a little bit in the ICU. And I was like, they're just chatting, hadn't gone back to work. And then it kind of dawned on me after the fact, oh, they were chaplaining me. They were there to check on me, you know? It was kind of nice that they were taking care of me, but I didn't catch on to that. I was busy. So, chaplaincy. Who else might be part of that response?
The pseudocode that I was involved
like any nurse that was near that room came in.
Right, you're around here and somebody's dying, you show up, see what you can do to help. Any other extra nurses?
That's all I was gonna say, anybody on the floor.
Oftentimes the pharmacist will show up as well.
Okay.
What's your code team, how do you know any given day, what's your code team like at Kennestone?
So Kennestone has 5 ICUs and then 2 IMCUs. So they will break it up into 3 and 3. So, that's 7. Oh, and then somebody has the board. My math is off. So they will break it up. Whoever's in charge, they'll split up the ICUs, but somebody will be meds, somebody will be compressions, and we take a Lucas with us, and somebody will be over quarter.
Most of them don't wear Lucases.
Oh,
Tell me what
I'm
Lucas is.
sorry. A Lucas is a compressions device. They take them on trucks with them. Now you'll pretty much see them. You'll hopefully see them a lot of places. They are a device that you have a board that goes under the patient, and then it's like a big C arm over top, and then there's a suction cup, and you will attach this drop down piece, and it will do compressions for you.
Oh, wow.
I'm pretty sure these in the ER at Mountainside, we aren't using them in the, outside of the ER, we're doing manual compressions at Piedmont Mountainside.
And then that way, if you have people in the field, both of the people should be free while compressions are still being continued.
Yeah, they've been huge in pre-hospital settings, so in the EMS, that's been a huge deal, because everybody's not tied up, like she said, if there's 2 people in an ambulance, 2 people on the truck, they could both be doing other things while the compressions are still going on.
And you have to make sure you put the suction cup in the right part, because if you put it too low, the xiphoid process can like break off and puncture a lung. So, placement is important.
So if you're an ICU nurse in any given facility, one of the things that you may find yourself on the code team for that day. So every place will have a different process. Sometimes it's always the charge nurse, sometimes it's not the charge nurse, it's just whoever the charge nurse has picked for that day. I mean, there's all kinds of processes. If you walk into the hospital at Piedmont Mountainside, you can find posted on MedSurg, posted in the ICU, there's a sheet that the house supervisor has distributed all over that has the names on it for that day's code team. Like who you can expect to show up. So who's the ICU nurse that's coming? Who is the MedSurg nurse actually goes to the codes, like if there's a code in the ICU over there, a MedSurg nurse will come over. They're not ACLS. But what do you think might be a role that MedSurg nurse can do? Follow orders, but even worse, so there's an important thing that has to happen during any kind of resuscitation effort, the documentation, right? So typically the med-surg nurse will be the one that will take the clipboard and call out, because what's happening as these, if you guys have seen, any of you that have seen a code, as you can think back, you've heard somebody say, okay, I'm giving epi right now, and so somebody has to document, milligram of epi, 11:10. You know, shocked at so many joules at 11:15. That somebody's got to document that, which is usually a flow sheet, or it may be in the computer. I don't know. Nurses are so resistant to doing things in healthcare in general. Like we have these wonderful programs, and yet they'll still write it out on paper. I don't know, and then transfer it over to the computer later. But I digress. However they document it, the documentation has to happen. There has to be a running list of what was given and when, and what was done and when, what interventions, what the patient was doing. So, do you need to be ACLS to document? Nope. So someone's gonna have to document. Should the patient's primary nurse be documenting? No. Why? Yeah. The patient should be elsewhere. So, that's, now, does that mean if there's nobody else there, does that mean that nurse doesn't? Nope. Okay, but we wanna make sure that we're keeping that person's brain available for trying to run through what went wrong and why, how it happened. So, that's a little bit about the roles in a code. Now, let's be real for just a second. We're talking about this on the very first day. You have sim scheduled very soon. I brought in a crash cart on the very first day to give you a little show and tell. Some of you might have a little inkling what your first sim might be like. Just saying. I'll tell you that to give you more time to panic. I tried to tell you that so that you won't panic so much, right? So that you get a chance to look over the crash cart, talk a little bit right now, this is why we're talking about this, the principles of delegation in the code and some of the different things that should happen. This is why we're talking about this now, so that you are prepared. Now, I've heard students say, well, I wish we could have done that at the end of the semester once we had more chance to see things in clinical before we go to sim. But I think that line of thinking is just a little bit backwards. The role of simulation is to give yourself a chance to learn in an environment where it's safe to make mistakes. I would much rather have you process through this in sim before you're a part of it with a real patient. I think that's a good thing, right? You're safe to make mistakes. You don't bring the mannequin back to life, well, you know anybody else all semester, it's a mannequin. Right? So it's not, this is okay, this is why we're doing it early. Why don't you all come kind of gather, well, I can bring this in the middle maybe. Just face enough. There are a couple, if you can't see, if you wanna get, I'm just gonna bring it right here. Well, yeah, if you want me back, where is it here? And still, if you can't see though, if you need to get to a different spot, then do so. I'm gonna have you all take a chance to come up here and actually handle things a little bit. So, this is a real cart. They're all gonna look a little different. Some places actually use repurposed, well, they're brand new, but I mean, not repurposed, that's the wrong word. Modified tool carts, like out of a mechanic's garage, okay? This one is manufactured specifically for this. So some things that you're gonna find on every crash cart. It's always gonna be a defibrillator. This is a real one, it's a little older, it's not quite the most up-to-date version, the pads are a little different that I think a lot of places are using now. You're using the ones with where you don't have to use the 3 leads, right?
No, we're still using the ones.
You're still using like this? Okay, these, cool, okay. We're more fancy at Mountainside than we are at Kingston. Alright, you'll find that, guys, actually, you'll find that some of the most cutting edge academic centers they'll have all this new fancy stuff, and then there'll be something that's like way old. Like it's bizarre, you'll just find that in hospitals, it's the truth of it. So, your defibrillator is always gonna be sitting there, there should always be combo pads. We don't have the actual paddles on our defibrillator. You'll still see those around sometimes. I can tell you that in 21 years of nursing, I don't think I have ever actually shocked somebody with the paddles. It makes really great TV, but why are these better when you're not on TV? Yeah, a whole lot less chance of somebody else getting shocked that doesn't need to be shocked, because you're gonna have to lean over the bed and rails and try to get on it. Nope, these get smacked on, and you know it. So one of the very first things that needs to happen when this crash cart gets put in the room is this. But there's something something else that needs to happen really, really early on. Picture doing compressions on a bed. Now most of the ICU beds, you can push a button that says CPR and it makes it hard and flat and firm. But think about just a regular old hospital bed. You're doing compressions on that bed. How's that work for you?
Not very good.
Why?
You have
It's
nothing.
soft and they're bouncy, right? So, this cart, if somebody is doing compressions, the very first thing that needs to happen when this cart gets in there, if somebody's doing compressions, is to make the compressions effective. You learned in BLS that high quality compressions is a priority, right? Long before you have an ACLS nurse, before the rest of the code team gets there, you need to make your compressions high quality. So how do you make your compressions high quality? Put a backboard underneath them, okay? This one happens to be in front of these drawers. Some of them, it's in the back of the cart. I mean, they may be configured different ways. Once you pull that board off from there, it exposes these drawers, okay? This particular, again, they can all be shaped a little different, but this has a space for a little tiny mini plastic padlock. I don't have any on this right now. A little plastic padlock. You don't open it with a key, it's more like a zip tie kind of thing, okay? You don't open it with a key, you don't have a combination, you rip it off. In this case, you pull that up there, and it rips right off and falls on the floor and it gets swept up later after the code, alright? But that little padlock, that little zip tie lock, will have a number on it. And as long as that number is, well, let me back up, nothing. If that lock is in place, if this hasn't been opened, then we are safe to count on all the drawers being full, all the meds being there, everything being clean, everything being ready to go. Once that lock has been popped off, it's no longer considered full and ready to go. The cart has to go back to pharmacy to be restocked, checked, expiration dates, everything to be restocked in there. If that lock is in place, it is ready to go.
And if it's popped for a patient, that patient will get charged for it.
Yeah.
So,
The crash cart use.
yeah, you don't wanna like, just walk around popping them off, you know?
Yeah.
Like, oh, I think the heart rate's 50, let's pop it. But you wanna,
You don't wanna get into it unless now, you don't, I mean, if you need something, you need
Right.
something, but yeah, you don't wanna pop it if you don't. So, because it also has to go to the pharmacy, they have to check everything, restock. So, once this is open, the little lock is off, you have drawers with medications in them. I'm gonna pass some of these around. These are not real medications, that's an empty box. Here, distribute some of these, would you? Send them around other tables. Cause I wanna show you something about how these are packaged. That's in box 2.
Had to give some of that away.
I'm keeping this one.
Where's the newest one?
This is why we can't have nice things. Alright,
Never seen a blood sugar mellow. He's terrible. Which one? What was it?
everybody that is lucky enough to have one of these in your hands, take it out of the box.
She went over there.
I've got this kind of like a vial here with medication. I've got the rest of the syringe here. Pop. Pop. Screw it in. And I've got a syringe ready to go. Okay? Remember, you have a sim coming up, and you're gonna have to give medicines out of this crash cart. I would strongly recommend, right now, you take a minute to practice how this goes together. The silliest little thing, but it's a thing. You gotta do it.
I don't know if
Okay.
you
So practice it, pass it around. Many of our, not all, but many of our emergency drugs are packaged that way. What are those even called? That type of packaging, do you know?
I don't know, but there's memes where you'll see a nurse
What do you
open it
pop out
versus
here?
a pharmacist. The nurses like shred the box and the pharmacist just quick
Yeah.
like with a knife and then
How do you? Oh, got it.
Glass vial with syringe. So most of these, the other thing I was gonna show you, so this is a syringe. If you were to just pull the whole thing off, there's a needle, listen, whatever, trust me. If you're to pull the green thing off, there's a needle down under there, but we're gonna be using all needleless systems in any place anytime soon. So take off, you just unscrew the yellow, and look at that, screws right into your IV tubing.
Oh,
It's a lure lock there.
fancy.
Okay, cool, you can keep playing with that while we talk. There'll be some other medications in here, Amiodarone doesn't have one of those. Yeah, there's Amiodarone. You'll have syringes, the crash cart probably not packaged. Yes, not all drugs are packaged like those. Amiodarone is just in a vial. Yes, you'll have to draw them up, I mean, they're all, epi, atropine, calcium chloride, adenosine are all gonna be in those type of boxes. Okay? We keep D50 in here, crash card, like our, so, your cart will have medications, it will usually have IV supplies. Patients' IVs always go bad in the beginning of COVID, like always. It's just a rule, you always have to start
I don't know how you would do this. If they don't have an IV yet, there's a needle in there. I don't know how to get the green part off. I think you just pull it. I was pulling pretty damn hard.
If the IV team comes, they're looking to
I
place
looked a little, but I'm scared to pull it because I don't know if I can get it back on.
I mean, they will, but they're more so there if you need like a larger IV.
Cause my thoughts are like,
If a patient has been in the hospital for a little while, just they need to have the IV. And then in a case like that.
But I mean, you need, well, if a patient is stable and then has a cardiac arrest, they're gonna need more access. So whether it's a midline catheter, like we learned about midlines last semester, or whether the docs are placing a central line, or whether it's just get anything we can get and get a peripheral IV, but you're gonna need access. How are we gonna give meds if we can't get peripheral, or if we can't get IV access? IO, right? We talked about that a little bit last semester too. That's becoming more and more common. Actually, the IO is becoming more. What's this?
The tube to, nope,
It's an endotracheal
just
tube.
kidding.
Take that off.
Wait, I was close. I was
Okay,
close.
you guys are gonna see these. Obviously, they would be packaged, not just named cards. But, you know, our examples in here. There's some airways, any idea what these are?
Different sizes.
They are different sizes of what?
Tricks.
Not quite. Yeah. It's the thing that holds the tongue. It's an oral pharyngeal airway, an OPA. So your patient that is having trouble with maintaining an open airway here in the back of their throat, this can go in.
Get it? Yeah, I got it.
Into their mouth. Can't use this one on a conscious patient, you're gonna gag them, they're gonna use it. Unconscious patient.
That's awesome.
The respiratory is there, but they may say, hey, hand me that, right? Because they're gonna be up at the head and there's gonna be a crowd. Hand them that.
Who
What
I
about
have
this one?
said with?
You know what this guy is?
Those are flashlights.
It is
Oh, no,
fun.
it's-
What is it?
You?
Nasal pharyngeal.
It is
No,
a
mine's-
nasal
one of mine's
pharyngeal
next
airway,
week.
an NPA. Or those? Right? So
I
this
was
one
like,
you can actually use on an awake person, goes in through the nose and down into the pharynx. You can do NT suctioning through this, you can suction a trachea by having this in there, well, you can suction a trachea through the nose too, but this gives you a nice path so you're not tearing up your nose. But you can do this one on an awake patient and have it not.
You also do the whole with another.
These also come in different sizes, size from, say it again, Troy? Size from? How do you size it?
Earlobe, doesn't matter.
Good.
And the nurse is allowed to use that? We insert,
Usually respiratory will do it if they're there, but yeah, absolutely, I put those in place.
we insert basically kind of like how we start and then.
Lube it, rub it in, and there's not a lot of finesse to it, I don't know, you got any tricks, there's not a lot of finesse, like, lube it, it's gonna go in,
Move it up.
kind of, usually to the side a little bit, and then straight up.
Do they come with you, or do you have to find them somewhere?
They don't,
What time is that? Is that one?
there's usually lube in the cart too, I don't know if ours has any, they're getting in the cart. We will
So
talk
what time
more
does the
about,
morning one end?
this, when we talk about respiratory, we'll talk about a lot more.
12:30
This
to
isn't your only
4:30?
chance to see these, ET tubes and that, we're gonna talk about all that when we do respiratory, okay?
Why'd you
I
tell
don't
me
wanna
that?
get too sidetracked into the details.
I was gonna be there
I
at
want you
1.
to see that you're gonna have, IV supplies, there'll be IV fluids, in our particular part, there's some IV fluids and tubing on these end pieces. But there's a little bit of quality control that has to go on to check, to make sure that this crash cart is ready to go in any given day. You know, we say that these things are always there, but someone better check it every day and make sure that it's there. And each facility may have a little different, process for that. Typically, a charge nurse is responsible for it, or, again, it may be somebody, it may be delegated, any nurse can do it. There will be I've only ever seen this on paper, have you ever seen anything but paper? No, just paper. This is a crash cart flow, or a code flow sheet, actually, this is a record that we keep for a code, so I don't have a checklist, but there'll be a checklist sitting on top of the crash cart. You're gonna have to check things like, is the defibrillator there? The defibrillator actually gets tested every day, I can show you another time how to test it, we can actually test ours or something. Not on a person or anything, I mean, you just shove it in a test plug and you tell it, turn the energy down and you have to go. There's gotta be an ambu bag, there's gotta be, many places, usually you'll have like a rapid sequence intubation kit, so basically like a toolbox that's sitting here with intubation tools, ours are just incorporated into the doors. But the things that you are gonna check on this checklist are the things that you can check without popping the lock off. So, are you gonna check exactly every individual medication when you do your crash cart check? No, what? You have the lock, right? You're gonna check and see what number is on that lock. Because when that lock gets popped off and a new one gets popped on, there's a new serial number on it. So you're gonna have to write down the number of the lock so that you can see it's the same lock. Nobody's taken it off, nobody's messed with it. But you're not gonna open the drawers and check every May. All those individual checks happen when the cart goes back to pharmacy and gets restocked between uses. Everybody follow me there? Okay. Always an oxygen tank. Oh, this is tempting as a student when somebody says, hey, go find me some EKG electrodes. And you see them, and they're just sitting right there on the crash cart, right out in the open, and you know right where they are, and you have no idea where else to look for them. Is it a good idea to take them off the crash cart? Do not take them off the crash cart. Don't take anything off the crash cart, okay? Except for when somebody put a Purewick left to sit on the crash cart, because they always get stuck in our unit. Well, I hope not. Good gracious. No, I swear over there, I don't know what, there's like Purewick stashed everywhere. I don't know what the nurses do.
Well,
I don't
since
know.
I'm before, because we were in the hospital one day, I keep on just pissing on the floor.
I digress.
It was horrible.
Don't take anything
I keep them on
off
the
crash
Dynamap.
cart, okay? EKG
I keep 'em on
electrodes
the
are there for a
Dynamap.
reason. The
The
defibrillator,
vital signs thing you roll
to
around.
use for some of them at least, to use the temporary pacing function you need these to put the little leads on, so don't take anything off. Questions? What else do you have to add? Cover everything we talked about?
Oh, suction setup.
Oh, yes, suction. There'll usually be a portable suction here too. Ours is not here. It's over there. But a suction setup. Because sometimes you're responding to a code, in the hole. You may not always have a suction on the wall. I'm pretty clear on the delegation and the principles of the delegation and roles, understanding that every place is gonna have a different setup, but you're pretty clear about what kind of some of those principles, how you decide who's doing what.
How is it sitting into a room? That might be a stupid question, but like, is
Whoever's
someone?
closest brings it.
Okay.
If you're standing next to it and they call a code on your floor, you absolutely can do it. One important step. If someone says, hey, grab the crash cart, unplug it. This is plugged in to the wall. And if you don't unplug it, guess what it's gonna do? It's gonna fall off the cart and on the floor. So this actually happened. So one of the nurses I worked with in the cath lab, she was precious and perhaps the kindest human being I've ever met in my life, and just a sweet voice. She was a very nervous thing. She was older. She was a lot older than me. She was getting ready to retire. She was a very nervous thing. She had very curly hair. One day, they had somebody wanted to be fed, which happens in the cath lab. But I mean, we keep this right next to the patient and hooked up to the stuff all the time. But she went to grab the cart to get it over to the patient, and she didn't unplug the defibrillator, and the defibrillator fell on the floor, and the cardiologist, who just doesn't get excited about anything, said, well, that's why they call it crash cart. So unplug the defibrillator before you run away with the crash cart.
I would cry for it.
So yes, that's a good question. Sam, if you're the closest person and someone says, hey, grab that crash cart, do it. That is also within your scope of practice. Okay, to bring the crash cart, get it there. Questions?
Is there usually more than one per floor?
Totally depends on the facility and how many beds on the floor, and every patient care area should have it. But how many, some places if it's for example, we have what is it, 20 beds, 30 beds or something on med-surg over there, and there's one on the main med-surg and one in the ICU, and then another one down in the auxiliary. Any separate patient care area is at least gonna have its own. Some of your bigger patient care areas may have two. A really big ICU might easily have more than one, easily.
So if you have two codes at the same time, kind of.
You're screwed.
That's what I was just thinking.
Well, you just go get one from the next area.
It's fine.
Is this gonna have fluid in it too?
Yes. There are fluids in here, in the bottom, and there's some fluids in here. If you guys could, any other questions? All right. what I'm gonna ask you to do is clear your stuff off